Okay, first section is just some general anatomy and information. Sacrum contains 5 segments. Coccyx contains 4. C1 is called the atlas. C2 is called the axis, containing the dens or odontoid. Cervical vertebrae have transverse foramen on the transverse process, and the vertebral arteries pass through this foramen. Intervertebral disc is called the nucleus pulposus, the inner portion, and the annulus fibrosus is the outer portion. The anterior longitudinal ligament is a fibrous tissue joining the vertebral bodies anteriorly and laterally, from the sacrum to the C1. It limits hyperextension, which is unique because others tend to limit flexion. Posterior longitudinal ligament is narrower and weaker. It runs within the vertebral canal. It attaches to the discs and it limits hyperflexion. Ligamentum flavum connects lamina of adjacent vertebrae and limits flexion. Interspinous ligaments connects to spinous processes. Supraspinous ligaments is more posterior, connecting C7 to the sacrum. Contrast-enhanced MRI of lower extremities. Coverage includes the iliac bifurcation down to the dorsalis pedis. Right and left common iliac arteries, the major bifurcation of the abdominal aorta. The posterior tibial artery supplies blood to the foot, a major branch of the popliteal artery. Anterior tibial artery supplies dorsalis pedis artery and a minor branch of the popliteal artery. Sylvian fissure divides frontal and parietal from the temporal lobe. The middle cerebral artery passes through the Sylvian fissure. Nasion is used as a landmark with brain positioning. A hemorrhagic infarct in the brain, a gradient echo sequence demonstrates magnetic susceptibility artifacts better. Insular cortex is folded deep within the lateral sulcus, between the temporal and frontal lobe. Has diverse functions including emotion, motor function, and homeostasis. There are 12 cranial nerves total. In DWI, the B value, the higher factor of the B value gives a stronger diffusion weighting, but higher B values give increased signal loss. Hippocampus is located in the medial temporal lobe, best seen on coronal obliques. Mesencephalic duct, aka aqueductus mesencephali, aqueduct of Sylvius or cerebral aqueduct, contains CSF, connects third and fourth ventricle. Vestibular schwannoma, aka acoustic neuroma, is a tumor of the vestibulocochlear nerve or the 8th cranial nerve. To see these, you need thin cuts through the IACs, 7th and 8th cranial nerves, seen on axials and coronals. Arnold-Chiari malformations are downward displacements of cerebellar tonsils through the foramen magnum, best seen on sagittals. Bell's palsy is facial paralysis from dysfunction of cranial nerve 7, which is the facial nerve. Multiple sclerosis is damage to fatty myelin sheaths around the axons of the brain and spinal cord. Vertebral arteries branch from subclavian through the transverse foramen, and the vertebral arteries merge to form a singular basilar artery, which gives blood to the posterior of the brain. That's the vertebral arteries. Dural venous sinuses are venous channels between the layers of dura mater. These receive blood from the internal and external veins of the brain, receive CSF, and they empty into the internal jugular. Temporomandibular joints are articular discs. They have articular discs which lie between the mandibular condyle and mandibular fossa. Internal carotids supply the anterior brain. External carotids supplies the face. And vertebral arteries supply the posterior brain. Internal carotids, anterior brain. External carotids, face. Vertebral arteries, posterior brain. Circle of Willis is visualized with 3D time-of-flight imaging. Note the right common carotid does not originate from the aorta, it's the brachiocephalic. Common carotids bifurcate at C3 and C4 into internal and external. Centering for a lumbar spine is 1 to 2 inches above the crest around L3. For intervertebral disc, you use oblique transverse planes to visualize. Conus medullaris is the terminal end of the spinal cord near T12L1. After this, it becomes nerve roots called cauda equina and filum terminale. With fractures, infection, or neoplasms, there's a loss of signal intensity on T1 due to loss of bone marrow. Rotator cuff is 4 muscles: supraspinatus, infraspinatus, teres minor, and subscapularis, SITS. The supraspinatus originates at the spine of the scapula and goes to the greater tuberosity. The abducts the shoulder joint. This is the most commonly torn. It passes below the acromion. The infraspinatus again originates at the spine of the scapula and also inserts to the greater tuberosity, and this externally rotates. Teres minor originates at the lateral scapular border and again goes to the greater tuberosity and externally rotates. And subscapularis originates at the anterior scapula and inserts to the lesser tuberosity and elevates the arm. So if you image a shoulder, the coronal oblique is parallel to the XY, or is in the XY plane and parallel to the supraspinatus. Kine-Box disease is a condition of osteomalacia in the lunate bone of the wrist. The collateral ligaments of the knee seen on the coronal. To see ACL tears, you need 15 degrees external rotation. The Achilles tendon joins the gastrocnemius and soleus. It's the thickest and strongest tendon seen on the sagittal slice. Wilms tumor is in pediatric kidneys. Islet cell tumors are of the pancreas. The celiac trunk is the first major branch of the abdominal aorta and branches into gastric, hepatic, and splenic artery. A zygos vein transfers deoxygenated blood from the posterior walls of the thorax and abdomen into the superior vena cava. MR enterography is used to see Crohn's or irritable bowel syndrome. It uses oral contrast called volumen. The prostate is inferior and posterior to the bladder. The endometrium is the innermost lining of the uterus. So back to the branches of the abdominal aorta from superior to inferior. It's going to be celiac, superior mesenteric, renal, and inferior mesenteric. The common iliac veins join to form the inferior vena cava. An aortic dissection is a tear in the innermost layer of the thoracic or abdominal aorta. These inner and middle layers separate or dissect, most common in hypertensive males aged 60 to 80 in the ascending thoracic aorta. aorta. Magnetic angiography uses gradient echo sequences. Time of flight is a T1 gradient echo, and it suppresses signal from stationary tissues. Phase contrast MRA uses T2 gradient echo and velocity-induced phase shifts for vascular signals. Laminar flow, blood flows at different but consistent velocities. Spiral flow is a spiral direction. Vortex flow is initially laminar flow. It intersects a stricture, becomes high velocity central flow, and spiral near the walls of the vessels. Turbulent flow is where flow fluctuates randomly. 2D time of flight MR angiography is used for large areas of coverage with thicker slices. Relies on flow related enhancement, stationary versus flowing spins. A disadvantage is there's high signal in background tissue. You must select a TE to allow for outer phase fat and water signals. Whereas 3D time of flight MRA is for smaller vessels with thinner slices. There's less suppression of background tissue than 2D time of flight. You need a longer TE, giving more time for dephasing with signal loss. Phase contrast MRA relies on velocity-induced phase shifts to distinguish moving protons and stationary protons. Has the most background suppressions, the longest imaging time, directional and velocity info from flowing blood. Increasing the velocity encodings allows more arterial vessels to be visualized. Some quick memory for the cranial nerves 1 through 12. On occasion, our trusty truck acts funny. Very good vehicle anyhow. Olfactory for smell. Optic for vision. Oculomotor, eyeball movement. Trochlea, eyeball movement. Trigeminal, chewing. Abductans, eyeball movement. Facial expression. Vestibulocochlear, hearing. Glossopharyngeal, taste. Vagus, swallowing. Accessory, swallowing. Hypoglossal, swallowing. Here's some anatomy as to where those nerves are at here. Again, here are the 12 cranial nerves. Again, olfactory, optic, oculomotor, trochlea, trigeminal, abductans, facial, vestibulocochlear, glossopharyngeal, vagus, spinal accessory, and hypoglossal. Next will be some information on the hardware and magnetism section. So location of coils from inner to outer, RF, gradient, shim, main, RGSM. Gradient amplitude is the strength of the gradient. Gradient rise time is the time to reach full amplitude in millitesla per meter or grays per centimeter. Also has a rise time. There's a trapezoidal gradient pulse here, so rise time, fall time, gradient amplitude, plateau or gradient peak strength. Gradient slew rate is the speed rate of ascent or descent measured in millitesla per meter per millisecond. A shorter rise time, faster gradients, gives shorter echo spacing, allowing for better resolution possible and more available slices per TR. 1 Tesla per meter equals 100 Gauss per centimeter. It's important to know the Gauss per centimeter for metallic implants found on MRIsafety.com. The duty cycle, aka gradient working time, is the time the gradients are on during the TR period, or the time the gradient can be run around max power. Affected by increased number of slices, using fat suppression, preset bands, and increasing ETL. Primary cause of noise in the MR room is the rapid successive switching of gradient coils. For sagittal slices, the X gradient is enabled. Coronal slices, the Y gradient. And axial slices is the Z gradient. If you use two gradients at the same time in slice selection, you get an oblique slice. E.g. the XY will give you a coronal oblique shoulder, parallel to the supraspinatus tendon. RF coils are closer to the patient again, and there's multiple powerful RF pulses, e.g. fast spin echo, multiple ETLs. These can lead to increased SAR tissue heating. So a 180 degree pulse is 4 times the power of the initial 90. There's 2 electromagnetic coils, transmit and receive coils. So managing SARS, which is your specific absorption rate in watts per kilogram, is a measure of the RF absorption. Larger patients will lead to increased SARS. With high SAR exams such as spine, long bones, pelvis, be careful of blanket use because the heat cannot escape. Avoid the shortest TR, which will negatively affect the pulse duty cycle, the gradient on time. Instead, use increased TRs to reduce your SAR. Minimize preset slabs or fat suppression pulses. Use the least number of slices with the shortest ETL. Enable flip angle modulation techniques. Use parallel imaging. Reduce phase encoding gradients. Use longer and lower amplitude RF pulses. And use transmit and receive coils. The room humidity should be between 50 and 70%, and the room temperature should be 65 to 75 degrees Fahrenheit. Local coils or surface coils, known as linear coils, use a smaller field of view and increase the XNR signal to noise ratio to improve the image quality. Cables should be braided straight in the bore, never on skin or coiled or looped. SNR penetration depth is half of the coil diameter. So a 6-inch surface coil can receive signal 3 inches deep into the patient. CP coil, circularly polarized transmit or receive coil, aka quadrature coil, has better SNR than linear. From a linear coil to a quadrature coil, your SNR is going to increase by 40%. Phased array coil uses multiple coil elements combined with multiple receiver channels. Permanent magnets or vertical magnetic fields use solenoid surface coils because the B1, the secondary magnetic field from the RF, must be perpendicular to B0. Sophisticated multi-element phased array coils acquire multiple channels of data in parallel, where parallel imaging allows for accelerated imaging. Parallel imaging has an R factor, and if the scan time will reduce proportional to the R factor. For some instrumentation, the patient image display and CPU are in the scan control room on the operator console. Array processor, which reconstructs data with Fourier transform, and the RF power amplifier are located in the MR equipment room. Magnetic field inhomogeneity is expressed in parts per million. Tesla is the SI unit for magnetic field strength, i.e. at the ISO center. A high field scanner is 1.5 Tesla or greater. If you double magnetic field strength, you will double your signal to noise. But your SAR is proportional to your resonant frequency. So if you double the field strength, you'll get 4 times SAR. Passive shielding is lining the room with steel. Active shielding is using superconductive windings in the MR scanner room, which oppose the MR field. Fringe field is measured in Gauss. So the FDA limits confuse me. So if you are between 0 and 1 month, you can only get 4 Tesla. If you're older than 1 month, you can get 8 Tesla. But how they word it is 4 Tesla for all and 8 Tesla over 1 month. A superconductive magnet is most common in MR. The field strength is increased by increasing turns of the wire or reducing spacing between the wires, and they use a horizontal B0. Liquid cryogens are used, so helium, and it's cooled to 4K, minus 270 C or minus 452 Fahrenheit. Additional magnetic fields or shimming adds to the magnetic field to make B0 more homogeneous. A quench is a sudden loss of superconductivity when the temperature is raised. You need to evacuate the room. There's a risk of asphyxiation or frostbite and damage to your tympanic membranes. So when the temperature is raised above the superconductivity threshold, the loss of zero resistivity is lost. So the existing current that is there now creates heat and boils off liquid helium. So the magnets associated with imaging are the static, the oscillating RF, and the time varying magnetic field, which is the gradient, and the TVMFs, which are these, are associated with muscle contractions, cardiac arrhythmias, visual light flashes known as magnetophosphines. The FDA limits time rate of change of magnetic fields, decibel per change in Tesla, to levels that do not result in painful peripheral nerve stimulation. Echoplanar imaging has the biggest effect of this. The body coil is an integrated part of the magnet which can act as a receiver coil. It's large and lacks large field of view, and it lacks high SNR of localized coils. Spatial encoding is done by the gradient system. The main magnet aligns the protons. Quality assurance maintains consistency. Are we operating equipment correctly? Versus quality control, is the equipment operating correctly? Associated with quality. SPT, System Performance Testing, or PIQT, Periodic Image Quality Testing. Center frequency is the operating frequency. Transmitted gain or attenuation, the units are decibels. So magnetism, the Larmor precessional frequency here is the gyromagnetic ratio times by the magnetic field strength in Tesla. So this gives at 1.5 Tesla, it's going to be 63.86. 63.86. The gyromagnetic ratio of hydrogen is 42.58. The chemical shift of fat and water is 3.5 parts per million. At 1.5 Tesla, this is 220 Hertz. Remember that the magnetic field inhomogeneity is also in parts per million. 1 Tesla is 10,000 Gauss. So a 3T system will be 30,000 Gauss system. Faraday's law says changing a magnetic field will induce a voltage. Resistive magnets can be shut off quickest in an emergency. Permanent magnets are heavy blocks of ferromagnetic plates. Ferromagnetic materials are iron and iron-like and generate a strong magnetic field. Paramagnetic are weak magnetic fields such as gadolinium. and diamagnetic have no magnetic field. So ferromagnetic are strongly attracted to the magnetic field, giving a missile effect, such as stainless steel, iron, and nickel. Magnetic susceptibility is the extent to which a material becomes magnetized in the external magnetic field. Magnetic permeability is how well a material attracts the imaginary lines of the magnetic field. So there's iron in the walls which attract the lines. The magnetic field is not allowed out. The net longitudinal magnetization is due to a tiny excess of protons in the lower energy state, which are parallel. These are aligned with the static magnetic field. Hydrogen in the higher energy state are anti-parallel. Magnetic vectors possess both magnitude, strength, and direction. Free induction decay is produced from an RF pulse. T1, also known as spin lattice relaxation, is a regrowth of longitudinal z-axis magnetization, and the T1 relaxation time is where there's a recovery of 63% of longitudinal magnetization of a tissue. T2, aka spin-spin relaxation, is a return of transverse magnetization to equilibrium. The T2 relaxation time is where there's dephasing to 37% of the original value. So some QC, this is to check the table is okay. You check the center laser light to the table, plus or minus 2 millimeters. Geometric accuracy, use a phantom, using a sagittal localizer, top to bottom, plus or minus 2 millimeters. Here you use an axial, plus or minus 2 millimeters. Spatial resolution is done here, so you see the observable holes. Next is going to be patient care. So nosocomial infection is acquired during a hospital stay. Iatrogenic is an event or reaction caused by a medical professional. Fomite is an object that carries a microorganism from one person to another, aka indirect. A vector-borne is via an insect. The general public is limited to the 5 Gauss line. There's an FDA recommendation of warning signs at the 5 Gauss line. Non-MR personnel have little to no training. Level 1 have limited training. And level 2 have extensive training. So for contrast, patients require a GFR if they are over 60, have hypertension, are diabetic, or have renal disease. Sedated patients are always monitored with a pulse ox. Normal heart rate is 60 to 90, tachycardia is over 100, and bradycardia is below 60. Technologists may administer O2 in an emergency. Most commonly is 2 liters per minute, average is 1 to 4. Contrast reactions are rare. In 1% of people, headache is most common. If there's bronchospasms, epinephrine is administered. High-risk patients are premedicated with prednisone or Benadryl. Etiology is the cause of a disease, and the latent disease phase is the stage of a disease where symptoms are not present. Enteral delivery of drugs is oral, sublingual, and rectal. Parenteral is any route other than PO or rectal, so IV, intramuscular, or subcutaneous. BID is twice daily, TID 3 times, QID 4 times, bi, tri, and quad. Reservoir is where pathogens thrive in numbers, Droplets are spread by sneezing, coughing, and speaking. The mucous membranes of the face, they travel a short distance of about 3 feet and they're not suspended in air. When you transfer patients, the urinary bag should be below the bladder. UTI is the most common nosocomial infection. Cycle of infection, pathogen, reservoir of infection, susceptible host, method of transmission. Contact isolation, need gloves and gowns. Droplet and airborne need masks. For TB patients, the patient and the tech wear masks. T-wave swelling or spikes, lots of names, aka Magnetohydrodynamic effect or Magnetohydrodynamic effect or Magnetohemodynamic effect. The flowing blood in a magnetic field causes charge separation, induces time-varying electric dipole. Basically, they will increase the amplitude of the T wave. It'll hinder the correct R peak detection, giving unreliable triggering and poor image qualities, mostly for cardiac imaging. There's a table for this next, but for SARS, the whole body limit is 4 watts per kilogram over 15 minutes. For the head is 3 watts per kilograms over 10 minutes. Eyes and testicles do not dissipate thermal absorption well. If you double your flip angle, you're going to get 4 times the RF absorption. You should avoid gradient echoes with implanted metallic hardware because it lacks the 180 refocusing pulse, which will aid in correcting inhomogeneities. RF heating is a concern with fast spin echo because there's multiple echo train lengths, giving increased tissue heating. Magnetophosphines was seeing stars. For the FDA, the level of concern is where the RF energy absorption increases body temperature by 1 degree Celsius. So for the ACR, level 1 is for the general public, or zone 1. Zone 2 is unscreened MR patients. Zone 3 is screened patients and personnel. And zone 4 is for screened patients under direct supervision. So here's the SARS limits. Whole body, 4 watts per kilogram over 15 minutes. Head is 3 watts per kilogram over 10 minutes. So these two drop straight down. The times drop down. Torso is 8 watts per kilograms for 5 minutes. Extremities is 12 watts per kilograms over 5 minutes. And that body core again was a 1 degree increase. Okay, onto some imaging now. So 2 processes occur after the RF. T1 relaxation takes a few seconds, whereas T2 relaxation is faster at milliseconds. T1 gives energy to surrounding tissue, spin lattice. It's a growth along the longitudinal magnetization, Z-axis regrowth. Fat has a short T1 and a short T2 relaxation time. Water has a long T1 and a long T2 relaxation time. The 2 extremes of contrast are fat and water. The Larmor frequency of hydrogen is higher in water and lower in fat, higher in water. The T1 time of fat is shorter than water. So the net magnetization vector in fat realigns with B0 faster than water. On T1, fat is bright, a high signal, and T2, water is dark. Water is bright. T1, water is dark, low signal. As if by magic, T1, water is dark, and T1, fat is bright. So basic T1 image has a short TR to maximize T1 information and a short TE to minimize T2 information. And then T2 is the other way around, so a long TR to minimize T1 and a long TE to maximize T2. TR controls T1 contrast. TE controls T2 contrast. If you increase your TR, you get an improved signal to noise ratio, you get a longer scan time, you get less T1 image, and you increase the available number of slices. Shorter TE gives you a better overall signal to noise ratio. So typical parameters for a T1, TR is going to be short 350 to 700, TE 10 to 30 milliseconds. T2 you want long, so 2000 to 6000 with a TE of 70 to 120. And proton density, you have a TR of about 1500, 3000, and a TE of 10 to 30. Again, here's some more ranges over here. Your basic scan time is your TR times phase matrix times NEX. As you can see, if you double your TR, you're going to double your scan time. To reduce scan time, you want to reduce your TR, reduce your NEX, increase your parallel imaging factor. You can use a rectangular field of view. Use half Fourier or half scan, and use the coarsest matrix as possible. Slice thickness directly affects signal to noise, resolution, and anatomic coverage. Okay. If you increase your NEX, you're going to increase your signal to noise by the square root of the percentage increase. So 2 NEX to 6 NEX, that's 3 times the amount. Root 3 is going to be 1.73 times the amount of signal to noise, or 73% increase. So 2 times more, you're going to get 41%. 3 times as more, 73%. And 4 times as many NEX, you're going to get double the signal to noise. Increasing NEX will increase signal to noise and increase scan time here, but NEX has no effect on pixel size. If you reduce your phase encoding matrix, you're going to get a higher signal to noise, shorter scan time, but you're going to get decreased spatial resolution due to an increased pixel size. Smaller pixel size, i.e. a higher phase matrix, gives improved resolution because smaller pixels, but decreased signal to noise. Voxel volume is adjusted by 3 parameters: field of view, slice thickness, and matrix. Signal to noise is going to increase with increasing your NEX, increasing your field of view, increasing your slice thickness, decreasing your phase matrix using bigger pixels, reducing bandwidth gives you more signal to noise, and reducing echo train length will increase signal to noise. Longer echo train lengths will increase chances of blurring. Reducing field of view will decrease signal to noise, but increase spatial resolution, because pixel size equals field of view divided by matrix. So a smaller field of view will give you smaller pixels, decreasing signal to noise, but increasing spatial resolution. If you reduce field of view by a factor of 2, it will reduce the voxel volume by a factor of 4, because you're halving them in both frequency and phase direction. So you're going to get a 4 times decrease in signal to noise. So if you increase your field of view from 256 times 512 to 512 times 512, you're going to decrease your signal to noise because there's less protons per pixel, and you're going to increase your scan time. So scan time formulas for a spin echo, TR times phase matrix times next. For a fast spin echo, TR times phase matrix times next, and then divide everything by your echo train length. A 3D gradient echo, TR times phase matrix times next, times by the number of slices. So, a scan time for a 3D gradient echo sequence with 100 TR, 10 TE, not relevant. 224 times 160, the phase will be the smaller number. 20 centimeter, not relevant. Flip angle, not relevant. Next is 1, 48 slices. So, TR times phase matrix times next times number of slices is this in milliseconds. So then what you're going to do is divide everything by 60,000 to get in minutes what that's going to be. So then 12 minutes and 0.8 minutes. So if you do 0.8 times 60 to get seconds, that'll be 48 seconds. So that's 12 minutes and 48 seconds. So the main thing is dividing this by 60,000 to get that into minutes, but then careful of the 0.8 because that is not 8 seconds or 0.8 seconds. It's going to be 0.8 minutes. So to find that in seconds, you have to do 0.8 times 60, 48 seconds. But if they ask for the answer in milliseconds, you'll just give them this number here. So pixel size again is field of view divided by matrix. Uses millimeters in the phase and frequency direction. Voxel size is a 3D volume element. Is phase times frequency times slice thickness. An isotropic voxel has equal measurements in all 3 dimensions, and these are best for reformatting an image. So for example, calculate the frequency and phase dimensions if they give you an 18 centimeter field of view and a 272 by 256 matrix. So 18 centimeters to get to millimeters is 180 millimeters. And there's 2 different dimensions to get this. So pixel size is field of view divided by matrix. So field of view is 180 for both. And so you plug in the matrices, 272 and 256 to give you 0.66 and 0.7 millimeters. So if you remember in the beginning, the smaller one is going to be your phase. So 256 is going to give you the phase number, even though it's bigger here. K-space is the storage location for MR signal data. For fast spin echo, the center of K-space is associated with contrast and high amplitude signals. The phase encoding gradient in the center of K-space has a less steep gradient, less steepness, more favorable signal and contrast. High resolution data is in the outer lines. Moving away from the center requires steeper gradient angulations. More lines and more detail, less signal to noise. Less lines filled gives an image with less spatial resolution. Spin echo will fill 1 line of K-space per TR, repetition time. A fast spin echo, the number of lines filled is the ETL. So a 12 ETL echo train length will reduce scan time by 12, increase blurring, increase SAR, but reduce signal to noise. If you increase your echo train length, you're going to reduce the number of available slices. So you need longer TRs to compensate. So longer echo train length, images will become more T2 and fewer slices are allowed. So reducing the available number of slices with a longer ETL. Echo spacing is the time between successive 180 echoes in fast spin echo sequences, 5 to 20 milliseconds. Echo of effective TE. The echo of your effective TE has the most signal, uses the least stressful phase encoding gradient. Elliptic centric K-space filling collect the low frequency, high amplitude data points at the start of the scan in a spiral fashion. In dynamic enhanced imaging for vasculature or visceral structures, contrast administered and K-space filled with centric K-space filling to visualize the contrast. In fast spin echo, the phase encoding gradient varies in strength and amplitude throughout the echoes. The gradient lowest for 180 pulse prior to the desired echo, ET. Half Fourier, aka zero fill, acquire just over half, around 60% of the phase dimensions of K-space, then interpolate the data with zeros, reduces your scan time but sacrifices signal to noise. Partial or fractional echo, half of K-space filled in the frequency axis. An acceleration technique is used to shorten TR and TE. Reducing your field of view will decrease signal to noise, but increase spatial resolution. Fast spin echo, the effective TE echoes are encoded with a low amplitude phase encoding gradient at the line closest to the center of K-space, K0. Here are the T1 relaxation and T2 relaxation, so spin lattice. So T1 is a fast process. You can see water takes a long time. This is your contrast here. Shorter T1 gives a more T1 image. White matter is very fast because of the fat on the myelin in white matter. T2, water is very slow to T2. A longer TE gives you a more T2 image. Again, white matter is the fastest and grey matter is after that very closely. Okay, all of these factors will increase your signal to noise ratio. So an increase in your TR, because there's more time for the longitudinal magnetization to recover. If you decrease your TE, will create a shorter T2 decay time, more transverse magnetization at the time of the echo sampling, less dephasing, producing an SNR increase. Increasing your NEX is increasing the number of times a slice is sampled, removing the noise, and image at a rate of the square root of the NSA increase. Decreasing your ETL will increase your signal to noise because it reduces the additional 180 RF refocusing pulses, increasing in an overall increase in SNR. Reducing your matrix or increasing pixel size because there's more protons per pixel. Increasing your field of view only increases the size of the pixel with more protons per pixel. Reducing the bandwidth or increasing water-fat shift. A more narrow receiver bandwidth has less noise sampled due to a smaller total frequency sampled. Increasing slice thickness will increase because there's more protons per pixel. Decreasing your parallel imaging factor increases the overall SNR. Increasing magnetic field strength generates a larger net magnetization vector. And using local surface coils will improve SNR in the anatomy of interest. Next are the factors that increase scan time. So increasing your TNR from the equation scan time is TR times phase times NEX. Increasing the number of slices, again, TR times phase times NEX is scan time. and increasing your next, TR times phase times next. Decreasing your echo train length will actually increase your scan time. You reduce the additional 180 refocusing pulses, increases the overall scan time, as the train of spin echoes shorten the overall scan time in a fast spin echo. So that's going to be your TR times phase times next divided by the ETL. So a smaller ETL will increase your scan time. Increasing your phase matrix, because TR times phase times next is going to give you a longer scan time. If you disable rectangular field of view, increases scan time because there's an increase in the phase encoding steps. Disabling half scan again increases the scan time by removing the mirrored K-space acceleration method. And decreasing parallel imaging factor due to more required lines of K-spaces needing to be filled. Next, we'll be looking at some image formation. So net magnetization vector is the excess protons aligned with the magnetic field. Free induction decay is the signal immediately after the RF pulse. Fourier transform is the process that digitizes MR signal. Raw data is stored on the computer prior to being processed by the Fourier transform. Each line of K-space is defined by the phase encoding gradient. 2D acquisitions require an interslice gap. 3D acquisition give greater signal to noise and eliminate crosstalk. SNR will increase with increased field of view and an increase in the number of slices or partitions. Reconstructing in multiple planes is advantageous in 3D plus sequences due to thin slices and an absence of interslice gap. Reconstruction algorithms of 3D data sets include MPR, multi-planar reconstruction, generating images in scan planes in addition to the acquisition scan planes, gives multiple slice plane orientations from one data set. MIP, there is two, maximum intensity projection and minimum intensity projection. Maximum intensity projection uses bright pixel intensities to create collapsed images of data sets, e.g. the bright blood in MRAs, time of flights, and MRCPs. Minimum intensity projections are software algorithms that use dark or hypo-intense pixels, reconstructed images, e.g. black blood in angiography. Receiver bandwidth is applied during the reception of the MR signal. Transmit bandwidth occurs during the transmission of the RF pulses only in slice selection. So transmit bandwidth, a lower bandwidth gives thinner slices or narrow bandwidth. During a transmission, the range of frequencies excites specific slice or volume. A low SAR mode is plus or minus 3.5 milliseconds. A longer RF pulses, good slice profile, reduced SAR because they're lower amplitude, less crosstalk, narrower gaps allowed, longer minimum TEs and TRs. Normal mode, plus or minus 2.5, good slice profile and optimized SAR. Fast mode, plus or minus 1.2 milliseconds, shorter RF pulse, compromised slice profile, higher SAR, higher amplitude, shorter echo spacings, shorter TEs and TRs, less susceptibility. Receive bandwidth, aka acquisition bandwidth, is an adjustable parameter, and it's the range of frequencies accepted by the receiver to sample the MR signal. So which frequency ranges from the echo are transferred into pixels. Narrow receive bandwidth has a higher signal to noise, but more chemical shift and increased susceptibility artifact. So you do not use a narrow bandwidth bandwidth with metal. If you halve the bandwidth, or a 2 times decrease, you will increase your signal to noise by square root of 2, or 1.41 times. A wide receive bandwidth has a lower signal to noise, faster data acquisition, minimizing chemical shift artifacts, used with a high readout gradient amplitude. Slice select gradient determines the scan plane and slice thickness. Must be turned on during the RF pulse. If you have 2 gradients at the same time, it's an oblique slice. A thin slice has a steep, high amplitude slice select gradient and a narrow transmit bandwidth applied at the Larmor frequency of hydrogen. The frequency encoding gradient, aka readout gradient, is turned on during the production of an echo and during frequency encoding. Sampling time is the time to sample the entire K-space line. Sampling time equals your frequency matrix, number of samples, divided by receiver bandwidth. So if you have a 256 frequency matrix and a 32 kilohertz receiver bandwidth, you will do 256 divided by 32 to get 8 milliseconds of sampling time. Sampling interval is the time between sampling points. Sampling rate is a signal sampling frequency. Nyquist theory says the sampling rate must be twice the sampling frequency to avoid aliasing. So we sample twice per cycle. Increase in receiver bandwidth needs an increase in sampling rate or frequency, i.e. sampling rate is proportional to the receiver bandwidth. Increasing receiver bandwidth results in increased sampling rate. Flow compensation, aka gradient moment nulling, compensates for first order motion, protons moving with constant velocity, and slow moving vessels. Flip angle affected by the strength and duration of the RF field. Increasing flip angle will increase your signal to noise up to a point called the Ernst angle, which is the optimal angle with maximum signal. Saturation mechanisms. Full saturation suppresses longitudinal magnetization. The net magnetization vector is flipped a full 180. Partial saturation yields T1 weighting. Occurs when the NMV is less than 90. And pre-saturation excites the H protons prior to the excitation pulse. Gives no signal on the image. In gradient echo, the flip angle is used to control saturation effects. Reducing flip angle while maintaining the TR reduces saturation. Rectangular field of view reduces scan time by filling less lines of K-space in the phase direction. Adjustments to voxel volume is achieved by adjusting the field of view, slice thickness, and matrix. Calculating slice distance totals or anatomical coverage. Slice coverage is slice thickness plus interslice gap. Total area coverage equals slice coverage times number of slices. So if you look here, 4mm slices, 1mm interslice gap, and there's 8 slices. So the total coverage is 4 plus 1 to give 5 times by 8 slices is 40 millimeters or 4 centimeters. So the radiologist wants 3.5 centimeters of coverage on a coronal thin slice pituitary. Slice thickness is 3 millimeters. Slice gap is 0.5 millimeters. They're asking how many slices are required to achieve the desired coverage. So the desired coverage is 3.5 centimeters or 35 millimeters. Each slice is 3 millimeters plus 0.5 slice gap, so 3.5 millimeters coverage. Number of slices needed is 35 divided by 3.5 to give you 10 slices. Next will be pulse sequences and image weighting with contrast info. A gradient echo has no 180 refocusing RF pulse, is more susceptible to magnetic field inhomogeneities. Your TR can be shorter, i.e. shorter scan times. It uses gradient coils to refocus the protons and create an echo. Gives T1 or T2 star characteristics, but there are influences from susceptibility, chemical artifacts, and inhomogeneities. Steady state is where there is residual transverse magnetization at the next excitation. It's when your T2 is less than the T2. Your TR is less than your T2. So steady state coherent gradient echo, aka T2 star, gives a high signal from fluid. Incoherent or spoiled gradient echo gives T1 contrast by removing residual transverse magnetization before the next excitation pulse. Uses additional RF pulses to spoil away steady state effects. Spin echo uses 180 RF pulses to refocus a decaying spin. In a conventional spin echo, one line of K-space is filled during each TR. A fast spin echo uses multiple lines of K-space, fills multiple lines of K-space during each TR. Tau is also known as half TE. It's the time between the 90 and the 180. And TE is the time between the 90 and the echo. So TE is 2 tau. TE is between the 90 and the echo, and tau is half TE. So here TE is between the 90 and the echo, that is TE. Tau is between the 90 and the 180. So TE equals 2 tau. And tau is called half of TE. Tau is also known as half of TE. A dual spin echo generates 2 images for every slice. The same TR but a different TE. Usually a short TE to give proton density and a long TE to give a T2. It has a lower signal to noise with a longer TE in the second image. So for 20 slices planned, there will be 40 reconstructed, 2 slices per TE. Fast spin echo, there's several echoes for each slice, collected during a TR. Scan time is reduced by a factor matching the ETL. More echo train lengths gives you a lower signal to noise and an increase in specific absorption rate. Multiple lines of K-space filled during each TR. If you increase your TSC by 3, gives you a scan time 3 times faster. So your effective TE are the echoes encoded with a low amplitude phase encoding gradient at the line closest to the center of K-space, K0. Increasing the number of echo train lengths can give an increase in blurring. A shot refers to the number of non-redundant RF excitations. Number of shots equals the number of phase encoding gradients divided by the echo train length. So a single shot sequence, the entire K-space matrix is filled with a single excitation and train of echoes. Useful in the abdomen to reduce respiratory motion. Multi-shot sequence, only a portion of K-space is filled. Yields opportunity for increased spatial resolution, e.g. a single shot would be a 128 matrix and an echo train length of 128. Inversion recovery begins with a 180, followed by a 90. So the initial 180 pulse is designed to null the signal from fat or fluid, depending on the length. Contrast is controlled by TR, TE, and TI. TI is your inversion time. It's the time between the 180 inversion RF and the 90 excitation RF. It's used to null signal from a specific tissue. And to do this, the TI should be 69% of the T1 relaxation time of the tissue. Your TI should be 69% of the T1 of the relaxation of the tissue that you want. So STIR is a short T1 inversion recovery, usually for compression fractures, lesions with retroorbital fat, MSK contusions. So about 150 milliseconds for fat at 1.5 Tesla. FLAIR is your fluid attenuated inversion recovery, e.g. a T2 FLAIR, used to evaluate the periventricular white matter. In the FLAIR, you're going to null CSF. Your TI is around 2000 at 1.5. 3D IR is a T1 weighted inversion recovery. Back to the spoiled gradient recalled echo. The RF pulse is phase shifted each time after the RF to prevent accumulation of residual transverse magnetization. Combined with a short TE to reduce T2, a T1 will predominate. So parameters here, TR is repetition time between the two 90 RF excitation pulses. TE is echo time between the 90 and the peak of the signal received. If you have a longer TR with a short TE, you will increase proton density weighting. Increasing the TE will decrease the available number of slices. A longer TE means fewer slices can fit into the TR period. Increasing the TR will increase the available number of slices and increase signal to noise. More or higher echo train lengths gives you a faster scan time. Reducing flip angle will give you less T1 information. The frequency encoding or readout gradient is on during the production of the echo. EPI echo planar imaging is the fastest sequence, acquires the entire MR image in a fraction of a second, uses a train of gradient echoes. Spin echo is a 90 degree followed by a 180 RF. Fast spin echo is a 90 degree followed by a train of 180 RFs. Inversion recovery is a 180 followed by a 90. And a gradient echo is a variable RF followed by gradients to produce an echo. Again, reducing the flip angle yields images with less T1 information. Increasing the flip angle increases the signal to noise up to the Ernst angle. Reducing the TE yields images with decreased T2 information. So for shorter scan times, decreasing your TR, increasing your ETLs, decreasing your NEX, increasing parallel imaging factor, enabling half scan. To increase your signal to noise, you're going to increase your TR, reduce the phase matrix, increase the field of view, reduce or narrow your receiver bandwidth, increase your NEX, and reduce the number of echo train lengths. So if these will make a longer scan time, increasing the DR, decreasing. These are all the opposites of the above. 450 TR with 30-degree flip angle combination will yield a T2 star gradient echo. 45 TR with a 90-degree flip angle will yield a T1 star gradient echo. So T1 images have short TRs and short TEs. A shorter TR means more T1 weightings. Spin lattice, and it's a recovery of 63% of longitudinal magnetization. Your contrast is controlled by your TR, and it's an anatomy scan. T2s use long TRs and long TEs. A longer TE means more T2 weightings. These are spin-spin. It decays to 37% of the original. Contrast is controlled by a TE, and it's a pathology scan. Proton densities have a long TR and a short TE. Flares have a long TR, a long TE, and a long TI. Intrinsic parameters cannot be changed, so T1 and T2 times, ADC, proton density and flow. Proton density is a tissue characteristic. Extrinsic contrast parameters are what the tech can adjust. So these are your flip angle, TR, TE, TI, TSE, and ETL. Structures that are always black on MR images are air, tendons, ligaments, metal, and cortical bone. So GAD contrasts are the most common, and they shorten your T1 relaxation time of nearby protons. They increase the rate from the high energy anti to the low energy aligned, anti-parallel to parallel, achieved by the thermal vibration of metal ions, oscillating EM field at the energy difference of the spin states. A routine contrast dose is 0.1 millimoles per kilogram or 0.2 milliliters per kilogram. So 143 pounds to get to kilograms divided by 2.2, 65 kilograms. 0.2 milliliters divided by that 65 kilograms gives a 13 ml dose. Most commonly used for enhancement of vessels in MR angiography and brain tumor enhancements due to degradation of the blood-brain barrier. NSF is nephrogenic systemic fibrosis, is fibrosis in various tissues and organs in the body. Patients with poor renal function are considered to be more at risk for NSF. So here are some pulse diagrams. So a gradient echo, there's no 180. So you can see your TE is here, and half is time tau is half of your TE, so either side. Your RF. Spin echo again has that 180 refocusing cup, 180 refocusing pulse. Inversion recovery has the 180 inversion RF pulse and your TI time, which is 69% of the TI desired. Here are some flow diagrams if you want to pause to take a look. Next is some cardiac info. So the right side of the heart receives poorly oxygenated blood from superior and inferior vena cava, sends them to the lungs. The left side receives oxygenated blood from the lungs, from pulmonary veins, don't forget veins, and pumps to the aorta. P wave is atrial contraction or systole, right here. QRS is going to be ventricular systole, QRS, ventricular contraction, aka the RT interval. T wave is ventricular relaxation or diastole, aka TR interval. So P wave, atrial contraction, PR interval. QRS is ventricular systole, RT interval. T wave is ventricular relaxation, diastole, or TR interval. Magnetohydrodynamic effect, moving blood gives electrical current and increases your T wave. In cardiac gating, the MR acquisition is triggered by the R wave using the RR interval, used to minimize pulsation, flow, and heart motion artifacts. RR interval, effective TR. To calculate this, you do 60,000 milliseconds divided by beats per minute. So 60,000 divided by 100 beats per minute will give 600 milliseconds TR for your RR interval. Trigger delay over on this side is the delay after the R wave before transmitting the RF pulse. This is your trigger delay after the R wave. Postpones acquisition until the heart is diastolic, in diastole. Trigger window is the waiting period before the R wave, expressed as a percentage of the RR interval. Available imaging time equals the RR interval minus the trigger window plus the trigger delay. So these two boxes taken out of this box. Perfusion cardiac imaging is the best method to evaluate for cardiac infarction. So just some heart anatomy here. So right atrium gets blood from the superior and inferior vena cava, goes through the tricuspid or atrioventricular chordae tendineae. Blood will then go this way through the semilunar valve, pulmonary, to go left and right, pulmonary arteries, because this is the unique situation where arteries are away from the heart, back to the lungs to get oxygenated, back to the left and right pulmonary veins, to the left atrium, going through the mitral valve, or bicuspid, or atrioventricular, into the left ventricle, which will then go through the aorta. There's brachiocephalic, left common carotid, and left subclavian. Another picture here, this is the mitral valve, this is tricuspid, bicuspid, aortic semilunar, and pulmonary semilunar. And some more images here. So here's blood flow into the right atrium, right ventricle, to the lungs, back, mitral, aortic valve. Onto some advanced imaging now. So diffusion MRI, each voxel has an image intensity measuring rate of diffusion, more sensitive to stroke. EPI is diffusion gradients applied to either side of the 180 to reduce motion artifact. Diffusion weighted imaging, diffusion gradients either side of the 180 in a single shot spin echoplanar. The first pulse dephases the spins and the second pulse rephases them if no net movement occurs. B factor, a higher B value gives more diffusion weighting. Duration, strength and amplitude of the pulses either side of the 180 in DWI. So pathology will be bright on the diffusion and dark on ADC. So for the opposite, normal tissue is dark on DWI and bright on ADC. A low ADC corresponds to high signal intensity, which is restricted diffusion. That's the dark ADC. Perfusion imaging gives sets of images which indicate flow characteristics, a vascularity of a given process, Measures the relative cerebral blood volume, RCBV. Differentiates tumours from non-tumours, a glioma grading. DSC, dynamic susceptibility contrast, aka T2 star grading, echo perfusion imaging. And DCE, dynamic contrast enhanced, aka basic T1 perfusion. Functional MRI, rapid pulse sequences when patient is at rest or performing a task, gives real-time evaluation of cerebral activity, thinking and dreaming, etc. Spectroscopy gives a chemical composition of a tissue, provides a spectrum of specific metabolites detected. To calculate pixel shift, you need bandwidth, field strength, and matrix. So if they give you 14.1 kilohertz above and below the central frequency, that will give a 28.2 bandwidth double. 1.5 Tesla means a 220 hertz chemical shift in water and fat. And the matrix here. So you'll need to get the bandwidth in hertz, so times by 1000. Then what you need to do is divide this bandwidth by the matrix to give you 110 frequency difference per pixel, and then the chemical shift of 220 divided by this frequency difference per pixel gives a 2 pixel shift between fat and water.